Alright, good afternoon everyone. Welcome to lecture 12 of BMS 300. Today we're going to wrap up with the integumentary system and then we'll start with the skeletal system, right? And just an announcement for all of you, what I cover on Wednesday is what will be on exam 1, right, which is the next Wednesday. And yeah, I do realize that there are starting with lecture 10 onwards, we haven't done the key questions and the poll everywhere questions. We'll get to it on Wednesday after we finish the skeletal system. So in the meanwhile, I would just encourage you to practice finding the answers on your own, and then on Wednesday when we go through it in class, you can confirm your answers, right? So that's my suggestion to all of you. So we talked about the various layers of the integumentary system last week, and we saw what are the various functions of those various layers. And today we're going to see how the different types of skin burns can be staged or classified depending on which layer is affected, right? And then we'll talk about how the regeneration of the skin or the healing takes place after different types of injuries, including burns and frostbite as well. And then we'll move on to talk about age-related changes, where it's not just the skin being wrinkled, right, getting wrinkled with as we age, but there are other changes happening both at the level of the cells and also at the appendages of the integumentary system. And then we'll finally talk about different types of pathologies, and just a trigger warning, if you don't like to see something squeamish, we will look at some images of pathology related to the skin which may be disturbing, right? So these examples include acne, warts, this condition epidermolysis bullosa as shown here, and also different types of skin cancers. So we see that the burn injuries can be staged or classified as 3 types, right? You have the first, second, and third degree burns. First degree burn is where the epidermis is affected, right? Only the epidermis is affected, and some of the clinical manifestations could be redness, pain, mild swelling, and the causes of this could include just getting a sunburn, right, or maybe touching a stove very quickly. So it is just a stimulus which has not had a long duration that can lead to a first degree burn. Now a second degree burn is where you have the epidermis and parts of the dermis also being affected, right? And this can include manifestations such as a deep redness. There will be greater pain. There can also be blistering, right? And the reason for blisters is that the integrity of the dermis is affected, and so the interstitial fluid has left that region, right? And so that could lead to blistering. Even though the upper level layer, the epidermis, may not be broken, still there can be fluid accumulation in the bottom, so that indicates the dermis is affected as well. And there can also be bleeding, because the dermis is where you have the blood vessels, right? And so there can be bleeding as well. And causes of second degree burns could be due to chemical burns, due to maybe boiling water falling on it, or even just touching a hot stove. And the third degree burn is where you have the epidermis, dermis, and the hypodermis being affected, and this can result in charred skin. It can become dry and leathery, and this is often painless. And the reason it's painless is because the nerves have been damaged, and so you're not able to feel pain in that region which is got a third degree burn. However, keep in mind that the regions surrounding the third degree burn area, they may have like a lower degree burn, like a second or first degree burn. So in those areas you can sense pain as well. And this could include fire victims and those suffering from electric burns. So with that, we move on to talking about frostbite, right? So frostbite is also known as freezing cold injury, abbreviated as in FCI, and this can be linked to exposure to temperatures lower than 0 degrees centigrade, right? So I don't know, for most of us, 32 degrees may seem fine, right? But it really depends from person to person, and we find that depending on which layer of the skin is affected, there's a similar staging system or a similar classification system for frostbites as well. So in this first panel, we see that there is no frostbite. This is the normal skin. A frost nip is where the epidermis is affected, whereas a superficial frostbite is where you have the dermis and the epidermis, and the deep frostbite is where you have the subcutaneous tissue being affected as well, right? And we find that this third type, deep frostbites, they are experienced by people who have experienced near-death experiences, and many of them are just fortunate to be alive. And in such cases, there would have to be amputation done, because once the tissue is dead, there's no way to revive it. So recently this article was published saying how there was increased cases of frostbite in the Denver area, and many times the reason for frostbite is not a lack of knowledge, but it's just the lack of resources to protect oneself from the cold temperatures. So now let's consider how the skin would heal after an injury to it, right? So the repair and healing can take place in two ways. The first one is called regeneration, and the next one is fibrosis. So in regeneration, we find that the damaged tissue is going to be replaced with the same type of tissue. So if the epithelial tissue is lost, it's replaced by epithelial tissue. If the areolar connective tissue is lost, it's going to be replaced by the areolar connective tissue. Whereas in fibrosis, we see that the damaged tissue will be replaced with fibrous tissue, and the consequence of this is there will be a loss of function. For example, let's say the cardiac muscle has suffered a lack of oxygen, and so this cardiac muscle cells die. That's called myocardial infarction. We find that rather than the dead cardiac myocytes being replaced with other cardiac myocytes, it's replaced with fibrous tissue, and as a result, that replaced region cannot contract, right? And so there will be a loss of function. But thankfully, as far as the epidermis is concerned, the epithelial cells and the areolar connective tissue has a very high regenerative capacity, right? And so let's see what are the various steps involved in wound healing. So there are 4 steps: hemostasis, which happens on day 1, followed by inflammation, and then which lasts for a couple of days, and then proliferation, which lasts for maybe a few weeks, and then the remodeling, which can last for many months. So in hemostasis, the main goal is to prevent the loss of blood, and in the way the blood loss is prevented is through these platelets, which are found in the blood plasma. They are going to help in the clot formation, right? So as these platelets aggregate, they can trigger clot formation, and the details of this is very complex, right? And you would have to take a more advanced course to learn about how blood clot formation takes place. So that's the first step. And then the blood vessels will also constrict. This is called vasoconstriction. That can also decrease the loss of blood. And then there will be this scab formation, right? So the scab will form because of proteins such as fibrin, and fibrin is also produced by fibroblasts, shown in the areolar connective tissue, shown here in green. And eventually there is also inflammation initiated, right? And I told you that this areolar connective tissue has got a number of immune cells. One of those cells are macrophages, which are capable of releasing cytokines, which can help recruit other cells, and it can trigger the inflammatory response. So in the inflammatory response, we find that there are white blood cells shown here, such as neutrophils, which is a type of macrophage, and then we have these macrophages. They're going to start phagocytosing the pathogens which may have entered in because of the injury. And there are also growth factors which are released, which will permit these fibroblasts to enter into that affected region. and there will be this will lead to the next step of proliferation. So the first step, hemostasis, is to prevent blood loss. The inflammation step is to prevent infection spreading, and the third step is where you have fibroblasts entering into the wounded region and providing collagen, right, to strengthen that area. Notice also the epithelial cells shown here in brown, the keratinocytes, they are starting to multiply and proliferate as well. And even the blood vessels which were damaged will also start to reform. So this can take a few weeks, and in the final step you have remodeling, right, of this damaged tissue. And here we see that the collagen fibers which were produced by the fibroblasts, they can be rearranged, the blood vessels can be further strengthened, and any of this scab tissue is going to be pushed out because there will be fibrous tissue which forms there. And also the epithelial cells, as they keep multiplying and they start moving to the superficial layers, this scab will be eventually pushed out of the way. So this last step of remodeling can take many months depending on the intensity of the injury. Are there any questions, folks, on the 4 steps of wound healing cascade? I hope you can appreciate how the cells we considered in the connective tissue play a role in this wound healing cascade, right? So now let's move on to talk about some age-related changes, right? So here's a picture of 2 individuals, and in the previous semester I tried to get everyone to guess what was their age, right? And majority of the class got it wrong. Only 7% got it right. And so the bottom line is, don't bet, right? And don't gamble. But the first picture is an image of a 62-year-old Native American woman who spends most of her time outdoors, right? Whereas this is the picture on the right is a picture of a 91-year-old Japanese monk who spends most of his time indoors. And the bottom line we see is that the 90% of the skin changes as we age happens due to exposure to the sun, right? So that's something to keep in mind. So now let's talk about what are the various changes which happen with aging, and you can divide this up into 8 different points, right? And the first 4 points, they're all related to changes which happen in the cells, whereas the remaining 4, they're related more to the appendages found in the integumentary system and also the types of tissue found there. So the first one is thinning of the skin. The skin will get more thin because the activity of the cells in the stratum basale is going to decline, right? And these are the cells which are mitotically active, they are rapidly dividing, so that division doesn't happen as rapidly. And also we find that the connections between the cells of the epidermis and the dermis will be weakened, because as we age you will realize that the protein synthesis will start decreasing, and proteins are the ones which are make up the cell junctions, and so with impaired protein synthesis you will have weaker connections between the cells of the epidermis and the dermis. Secondly, there's also an increased risk of infection. The skin becomes less sensitive to responding to infections because the number of dendritic cells or the Langerhans cells is going to decrease by 50%, right? And even when there is injury to the skin, the repair won't happen as rapidly, because in the previous point we see that the cells of the stratum basale are not dividing as rapidly. And then point number 3, we see that the hormone production by the skin is going to decrease, and an example of this is the production of the vitamin D precursor. You guys remember the precursor's name? 7-dehydrocholesterol. Thank you so much. I'm so glad I heard the letter 7-dehydrocholesterol. That is going to be found in the skin, and if you have thinner skin you have less substrate, and as a result less vitamin D will be produced. The skin becomes paler because the melanocyte activity will decrease, and as a result, we find that there isn't as much melanin pigments being produced. So I hope you can appreciate how these 4 points, they're all linked to impaired cellular activity of different types of cells. And now we're going to move on to see what changes happen in the specific appendages. So the first appendage I want to point out is the sebaceous gland, highlighted here. And as you have decreased glandular activity in the sebaceous gland, the skin will become more dry, because this makes the skin lubricated and moist. And also the blood vessels, the amount of blood supply is going to reduce, and as a result, older individuals can feel colder, because it is this blood vessels which their flow is going to be modulated according to the surrounding temperature. But if you have less blood flow, that can affect the temperature regulation. And the hair follicles, they are also going to reduce in their functionality, so the hair becomes thin, or they can also lead to hair loss as well. And finally, wrinkling is probably the characteristic most of us are familiar with, and this is because the elastic fibers, they're going to decrease in size. Elastic fibers are made by fibroblasts, and also the collagen fiber synthesis can reduce, and all of this can lead to the skin wrinkling as well. Are there any questions for me? Alright, if there are no questions, we can talk about a few examples of pathologies, right? So the first one is acne, and this is going to affect 85% of the population between the ages of 12 to 25. And we are going to see a couple of reasons for acne formation, right? Firstly, we see that it's caused by an overproduction of sebum by the sebaceous glands. And sebaceous glands, they are going to respond to the stimulation from the androgens, and when puberty is reached, the androgen levels increase not only in males but also in females, and we will talk about the relevance of androgens in males and females when we discuss the reproductive system. And so that's the reason for increased sebum production. We also see that the sebum is going to carry not only the oil secretions but also skin cells to the surface as well. And so here's a picture of the sebaceous gland, right? And as it's pushing the sebum outward, we see that the cells on the upper layer of the epidermis, they're going to shed, right? And that is shedding of the cells is known as desquamation. And if these cells are not shed in a uniform way, it's called abnormal desquamation, and that can cause these pores to get clogged. And when the pores get clogged, we see that there will be accumulation of sebum under the skin, and this leads to that bump, which is called as a comedo. And the comedo has got a white head, right? Because the sebum is still under the skin, but the moment the sebum is exposed to the atmospheric air, it gets oxidized and it turns into a blackhead. That's how the white head turns into a blackhead. So just to summarize, two causes are abnormal desquamation and increased sebum production due to androgen stimulation. There's other causes too, but it's beyond the scope of our discussion. Happy to discuss this with you after class, right? Now the second type of pathology we'll talk about is the common warts, right? And this is the second most common complaint after acne. And the reason for this is the abnormal growth of keratinocytes. And the reason these cells get abnormal is because of infection from the HPV, or the human papilloma virus. Now there's a higher risk of infection from HPV if there is open sores, right? And as a result, this can result in the skin can have this rough raised appearance. And we will talk about HPV when we discuss the sexually transmitted diseases in the reproductive system. And once you're infected with HPV virus, there's no way to be completely free of the virus, but there are ways in which the symptoms can be treated. For example, the warts can be removed through cryotherapy, maybe topical medicines, or even surgical approaches can be used to remove the warts as well. So with that, we move on to the third type of pathology, and that is the epidermolysis bullosa. So I want to break down this term to you, and this is a picture of a child who is affected with epidermolysis bullosa, right? And so the term bullosa means large blisters. Right? Bullosa means large blisters, and lysis means to tear or to break. We talked about glycolysis, where the sugar is broken, and this is referring to the epidermis, the topmost layer of the integumentary system, lysing, right? And that's the reason why there are these blisters forming. Now there are three types of epidermolysis bullosa, and the three types are EB simplex, junctional EB, and dystrophic EB, and the term EB is just to abbreviate epidermolysis bullosa because it can be a mouthful. And these three types of EB is based on which part of the cells in the epidermis are affected, right? So we find that there could be a problem in the tonofilaments, right, which is the cytoskeletal proteins. It's just the intermediate filament in the epidermis. There could be a problem with the hemidesmosomes, which connect the epidermis to the dermis. Actually, it connects it to the basement membrane, shown here in blue. And then there could also be problems in proteins which connect the basement membrane to the lower layers of the connective tissue. So we find that if you have abnormal cytoskeletal proteins, that can lead to epidermolysis bullosa simplex, where this lowest layer of the epidermis is going to tear off. Or if you have problems in the hemidesmosomes, which anchor the epidermis down to the basement membrane, it can lead to junctional epidermolysis bullosa. And if you have problems in the proteins which anchor the basement membrane to the underlying areolar connective tissue, you can have the dystrophic epidermolysis bullosa. So the reason I put this picture of a chain here is that there's a saying that the strength of a chain is determined by its weakest link. Thank you. Right. So it doesn't matter which part of the epidermis is affected, whether it's the cytoskeleton, hemidesmosomes, or the proteins which anchor the basement membrane to the underlying layers. Any of these have a problem, it can lead to these blisters. So we see that epidermolysis bullosa can have a few complications, right? And this is common to when you have the outer layer being lost, right? So it could, even if you have a burn injury, right, it can have similar complications. But we see that losing the epidermis is going to increase the risk of infection, right? And one of the infections can be from the bacteria, and when the bacteria starts entering the bloodstream, it can lead to this condition called sepsis. And sepsis can be life-threatening. It can progress pretty rapidly, and it can lead to the shutdown of multiple organ systems. So bacterial infection is one of the risks or complications arising from epidermolysis bullosa. We also find that there can be malnutrition, because if you have this type of blisters in the mouth, it can make eating very difficult, and if you're not eating well, that can lead to deficiencies, and it can also lead to impaired production of the red blood cells, right, which means it can lead to anemia. And I said that the epidermis has got these glycoproteins which are produced by the keratinocytes, which make the epidermis water resistant, right? And so not only will it prevent water soluble substances from entering into the skin, but it can also prevent the loss of fluids, and loss of fluids due to epidermolysis bullosa can lead to this type of blisters. Is this clear, folks, how all of this happens? So with that, we can move on to the last type of pathology, and this is skin cancers, right? So we find that the UVA and the UVB radiation from the sun can increase the risk of skin cancer. And this is the fastest type of growing cancer in the United States, and it's the most commonly diagnosed cancer for malignancy. And what we mean by malignancy is that the cancer is able to spread from one part of the body to the other parts, right? And this surpasses the lung cancer, breast cancer, colorectal, and prostate cancer as well. Now here are a few statistics about skin cancer. We find that it is the melanoma, or the cancer of the melanocytes. It's going to be the second most common form of cancer in females between the ages of 15 to 29. And the main reason for this is tanning salons, right, where there's exposure to this UV rays. And over the last 40 years, the rates of melanoma have increased by 800% in females and by 400% in young males, right, between the ages of 18 to 39. And again, this is all because of exposure to the sun and tanning salons. Yes? I think it is multifactorial. So when you look at statistics like this, it doesn't explain the mechanism. It could be due to more testing. It could be due to increase in the population as well. So yeah, but it's just, these are just facts, right? And it's been shown that having more than 5 sunburns is going to double a person's risk for melanoma, and especially if this sunburn happens during childhood or adolescence, it's going to more than double the risk for developing melanoma. Now the reason for this is the cells in the integumentary system are most active in younger people, and as we get older, their activity decreases, and when they are more active, that's when there's an increased risk of mutations from these UV rays. But the one good news is that when there's early detection, the 5-year survival rate is around 99% for melanoma, even though this is the most deadly form of skin cancer. So here's the question for you. Which of the following layers of this do you think that skin cancer will not originate in? Right? Do you think it's the stratum basale, stratum spinosum, stratum granulosum, or stratum lucidum? Okay, most of you said stratum lucidum, and you are right. Okay, and here's the reason why. In stratum lucidum, the cells are dead, right, and the organelles have disintegrated, and you don't have a nucleus, and no nucleus means there's no DNA to be mutated, right? So we find that anything below the stratum lucidum, like starting from stratum granulosum onwards, you have cells with the nucleus, and so there can be skin cancers arising from these layers. So we see that there have to be cells with a nucleus, and we're going to talk about 3 types of skin cancers, and the classification is based on which layer is affected and which cells are affected. So squamous cell carcinoma can arise in the stratum spinosum or stratum granulosum, right? So this has to arise in a cell which is squamous or flattened, and we find that there are flattened cells in stratum spinosum and in stratum granulosum. And the term carcinoma means it's a cancer of the epithelial cells. So I hope this name makes sense to you. And then there is melanoma, which is going to arise in the stratum basale because the melanocytes are in the stratum basale, and from there they are going to send out the dendritic projections for passing on the melanin pigment. And then the last type is the basal cell carcinoma, and as the name indicates, this will affect the stratum basale, right? And this is the cancer of the epithelial cells. So we see that melanoma is going to originate in the melanocytes, and the type of pigmentation which is produced by these cancerous cells can vary, and this is highly metastatic, right? And this is the most deadly form of skin cancer. On the other hand, the basal cell carcinoma, it is the most common, but it is also the least metastatic, right? And this is a very slow growing cancer, and we find that the cells, when they are proliferate, they are going to invade down into the hypodermis, into the lower layers. And we find that most of the basal cell carcinoma can be cured by surgical excision, right? And because this is going to move down into the hypodermis, it's going to appear as a pearly bump, and it's not going to break the upper layers of the epidermis. Now, this is in contrast to a skin cancer which originates in a more superficial layer, like in the squamous cell carcinoma. That will result in this rough, scaly patches, and it can even lead to bleeding as well, because the more superficial layers can be affected. And the melanoma is where you have the cancer where there is pigmentation, right? And we can characterize a mole or an abnormal appearance of the skin as a melanoma based on 5 different characteristics. And these 5 characteristics, they can be summarized as the ABCDE rule, and I will hold you responsible for what each of these letters stand for and what they mean as well. So A stands for asymmetry, where the 2 sides of the pigmented area do not match, right? So that could be an indication. B stands for border, where if the border is irregular and maybe it has these indentations. T stands for the color or the pigmented area, and this pigmentation can really vary. It could be brown, tan, maybe red, or even blue. And D stands for the diameter, but before that, just notice that this is a normal mole, whereas this is an abnormal mole, and the main difference you see is the coloration, which is very distinct in this abnormal mole. And D stands for the diameter, and if it's more than 6 millimeters, which is the size of a pencil eraser, that can indicate it may be melanoma. And finally, E stands for evolving, where it is changing in its appearance over time, right? So these are examples of this is what is meant by this ABCDE rule, and by looking at these 5 characteristics, you can determine if it's a skin cancer, melanoma, or not. So let me summarize what we've been discussing thus far in the integumentary system. We talked about different types of injuries, and we saw how burns and frostbites can be staged and classified based on which layer is affected. And the regenerative potential of the skin is best when the injury is most superficial, and also pathologies can be associated with different layers which are affected in the integumentary system. And we talked about acne, warts, epidermolysis bullosa, and also 3 types of skin cancers. Alright, so with that, we complete the integumentary system, and we can move on to the skeletal system. Are there any questions? Are there any slides where you guys didn't have a chance to write down the notes? Want me to go back to? You're good? Alright, fantastic. Alright, welcome everyone to the skeletal system. Right? So here's an overview of what we'll be discussing for the next 16 minutes, right? So we're going to talk about how the bones can be classified based on 3 things, right? So we see that bone classification can be based on the location of the bones. So they could either be bones which are part of the axial skeleton or the appendicular skeleton. So we'll see how that classification is done. Then we'll see how bones are classified based on their shape, right? So there could be 6 types of shapes, and each shape has a unique type of function, right? And you don't need to know all of those functions, but we'll just look at a couple of them in more detail. And regardless of their external shape, internally they would have compact bone and spongy bone, right? So compact and spongy bone is something I mentioned in the connective tissue when we discussed that. We'll see how these types of bone develop, and then we'll talk about the gross anatomy of bone, specifically in the compact bone, and we'll see how cells are organized, and then we'll talk about the spongy bone organization in tomorrow's lecture. And then we'll see how the bone development and formation happens in the fetus through endochondral ossification and intermembranous ossification as well. Right, so these are two ways in which the bone formation can take place. So with that, let's start with the difference between the axial and the appendicular skeleton. So the axial skeleton is made up of 80 different bones, and this is shown here in yellow in both of these panels. And this includes the skull, the vertebral column, the thoracic cage. And the main purpose of this axial skeleton is to provide points of attachment for the various muscles in that part of the body. And it also offers protection to some very vital organs. For example, the brain is housed in the skull, the spinal cord is in the vertebral column, the heart and the lungs, they are in the rib cage, and so this offers protection for some vital organs. We see that the appendicular skeleton is going to refer to all of the bones which make up the upper limbs and the lower limbs, right? So we find that the upper limbs, they are connected to the axial skeleton by the pectoral girdle, whereas the bones of the lower limbs, the lower limbs are connected to the axial skeleton through the pelvic girdle. So we see how bones can be classified based on their overall location as being in either the axial or in the appendicular skeleton. So next we'll talk about the shape of the bones, right? So we see that some bones can be flat. An example of that is the sternum, but also there are a lot of flat bones in the skull as well. There are long bones in the body, and this is the most common type of bone in the body, where the length is greater than the width. And there are also these bones called sesamoid bones, which are shaped like sesame seeds, and they are found in different parts of the body, but one of the most distinct examples is the patella bone found in the knees. And then there are also a number of irregular bones. For example, the entire vertebral column is made up of irregular bones. We'll talk about the sinuses in the which make up the facial bones when we discuss the respiratory system. And then there are these short bones which are found only in the wrists and in the ankles, and they are more cube shaped, where their length is similar to their width. So that's the main difference between short bones and the long bones. And then there are also these sutural bones which develop after birth, and they connect the various parts of the bones of the skull together, right? And these sutures are not there during childbirth, but afterwards these sutural bones will develop. So regardless of which of these bones you take a look at, we find that internally they can have spongy bone and also compact bone. So the spongy bone is also known as trabecular bone, and as the name indicates, it is 50 to 90% porous, whereas the compact bone, on the other hand, it's only 10% porous, and this is going to constitute 80% of the adult skeleton. Now the functional relevance of the compact and the spongy bone we will consider in the upcoming slides, but let's just take a look at the gross anatomy of the flat bone and compare it with the compact bone. So in the flat bone, such as the ones found in the skull, we find that there is going to be a spongy bone in the middle, right, and on either side you have compact bone. So it looks like a bone sandwich. So spongy in the middle and compact bone on either sides. Now the functional relevance of this is mainly protection. I told you the skull is going to protect the brain, and so even if there is an injury to the skull, and let's say the compact bone on the outside breaks, the deeper compact bone will still be intact, and that will protect the brain from being pierced by the shards of bone, right? So that is a protective function of the flat bones. Now, long bones, on the other hand, they are mainly going to facilitate movement, and we find that the spongy bones in a long bone like this will be in the two ends, right? And these two ends are known as the epiphysis. So, and the part of the epiphysis which is closest to the central axis of the body is called the proximal epiphysis, whereas the part of the epiphysis which is further from the central axis of the body is called the distal epiphysis. So the terms proximal and distal, they are very used very often in anatomy to describe the location of something, and closer to the point of attachment is called proximal, whereas distal means further from the point of attachment. Now there is this long narrow shaft known as the diaphysis, which is found in between the two epiphyses, and it is in this epiphysis where you have the red bone marrow found, and we'll see how this red bone marrow gets there in the first place. And in the diaphysis you have the yellow bone marrow found in the cavity of this diaphysis known as the medullary cavity. So the diaphysis is it's hollow, and in that hollow space you have the yellow bone marrow. So now let's take a look at the function of the red bone marrow. So this is just a cross-sectional view of the bone at the epiphysis, and the red bone marrow is going to be the place where the red blood cells form, the white blood cells form, and also the blood platelets. So that's where hematopoiesis is going to take place, where all the cells in the blood are going to be produced. On the other hand, the yellow bone marrow, which is found in the diaphysis, it contains a lot of adipose tissue, and that is the reason why it is used in a number of cuisines. Have any of you here tasted bone marrow? Yes. Is it good? Yep, it's pretty good, right? And so, sorry to gross you guys out if you haven't tried it, but it's the fat in it which makes it tasty, right? One of the things which makes it tasty. So now let's move to talk about the other parts of the long bone. There is this narrow region called the metaphysis, right, which is connecting the epiphysis to the diaphysis, right? So you have metaphysis on the two sides of the long bone, two ends of the long bone, and the reason I point this out is there's going to be a narrow line there called the epiphyseal plate in children, but in adults it's called the epiphyseal line. So the epiphyseal plate is made up of hyaline cartilage, but eventually it can turn into the epiphyseal line, which is just bone tissue. So this is what it looks like when you look at an X-ray, right? So here's the epiphyseal line shown as the dark region, whereas the epiphyseal plate shown as the dark region in the child's X-ray, whereas in an adult you see that there is bone tissue shown by the light color. So a basic question is, why are bones appearing light in an X-ray, right? And the reason is bones are rich in calcium, and calcium can absorb the X-rays, and that's why it appears bright in the X-ray, whereas the surrounding tissue and the cartilage also doesn't have calcium, and that's why it is going to as much calcium. That's what appears darker in the X-ray. And this presence of the epiphyseal plate versus the line is what can be used in forensics to determine the age of the skeleton, right? The age of the person's skeleton by looking at this epiphyseal plate versus line. So let's take a close look at the compact bone. So the compact bone has got these microscopic structural units known as an osteon. So the osteon looks like a cinnamon roll, right? It's got these concentric circles in it. I know it is lunchtime, right? So it's got these concentric circles in it called lamellae, and in this lamellae you find that there are these cavities known as lacunae, which is the plural, singular is lacuna, and these are cavities or lakes, right? And in this lake is where you would find the osteocytes. We talked about chondrocytes being found in lacunae in the cartilage. Here you have osteocytes found in the cavity, and each of these cavities, they're going to be linked to one another by these narrow channels known as canaliculi, right? So each of these lacunae. They're linked by these narrow channels, and there is fluid in the lacunae, and so fluid can flow from one lacunae to the other through these canaliculi. And also these osteocytes, they have these dendritic projections through which they can interact and communicate with the neighboring osteocytes as well. And so because of this fluid in this lacunae and traveling through the canaliculi, there is possibility for nutrients being transported to the osteocytes, waste products can be taken away, and there can also be communication between the osteocytes through the this fluid passing back and forth. So notice that the osteon structural unit has got this central canal in the middle where you have blood vessels, nerves and lymphatic vessels flowing through, and all of these are interconnected through this fluid system pathway. We notice that also there are these canals which are going to be found in perpendicular. So this is a central canal which is found vertical to the bone structure, whereas these perforating canals are found in a horizontal manner. And there can be fluids which flow all the way from the periosteum, which is the connective tissue surrounding the bone, all the way to the endosteum, which is going to be the membrane lining the medullary cavity, right? So we'll take a closer look at the endosteum and the periosteum in the upcoming slides. But before that, I just want to show you how the osteocytes communicate. So this picture on the left is showing you how many dendritic projections are arising from a single osteocyte, right? So it's pretty complex. Here is a simplified representation on the right hand panel. So we see that many of the structures we considered in cells, right, in the previous lectures, they're also found in the osteocytes as well. For example, here are the focal adhesions, right, which are connecting the projections of the osteocytes to the surrounding bone matrix. And then here are the cytoskeletal proteins found inside the osteocytes. And then here are the gap junctions. So here between the two osteocytes and their dendritic projections can communicate with one another. And finally, there are also ion channels here found in the osteocytes as well, right? So this is just to show you what are some of the structures found in osteocytes which we see in other cells. Okay, so here's the last slide for today, right? What is the difference between the periosteum and the endosteum of the compact bone? So periosteum is this thick sheet of connective tissue, right, and it's going to contain lymphatic vessels, blood vessels, nerves, and the purpose of this connective tissue with all of these vessels is to nourish the compact bone. And we see that this periosteum has got two parts to it. There is a fibrous layer, outer fibrous layer, and this inner cellular layer. Now let's look at a different representation of the fibrous and the cellular layer. So notice that this bone is facing this way, the other bone is facing the other way. So the fibrous layer is going to contain fibroblasts, no surprise, which make their surrounding matrix, and there are also blood vessels here. Whereas the cellular layer, it's got this SSC, which stands for the skeletal stem cells, and we'll talk about this in the upcoming lecture on Wednesday. And there are also other types of cells. So the periosteum is what is going to link to tendons, and it can also link to ligaments, right? So that's why we need to consider the periosteum. Now the endosteum, on the other hand, it's this membrane which lines the medullary cavity. So here's the medullary cavity, and it's going to be lined by the endosteum. Now the various components of the endosteum shown here include a number of cells such as the osteoclasts. There's an osteocyte shown here surrounded by the bone matrix. There are also these osteogenic stem cells, and then there are these osteoblasts as well, right? So we will talk about the function of each of these cells when we come back on Wednesday, and we'll also compare how the compact bone structure is going to vary with the spongy bone, right, when we get back on Wednesday. Thank you all for your time.